Cornea in short. You look at a cross section up to here, you have the epithelium, microvilli and glycocalyx. Basal cells have fluid accumulation in corneal edema. Between the Bowman's membrane and the Descemet's membrane, we have the stroma. Stroma contains glycosaminoglycan. They make it hydrophilic to absorb water, and it's filled with keratocytes, which are basically fibroblasts, and they produce collagen. The collagen fibrils are arranged pretty regularly over here. They are called corneal lamellae. Plus, the cornea entirely is avascular and relatively dehydrated as compared to other eye structures. As a result of these three factors, the cornea is able to remain transparent. But in case you have damage to the endothelium or compromised sodium-potassium pump, or if you have extra GAG or mucopolysaccharides in the stroma, or your IOP in general of the eye is raised, then you might have increased fluid accumulation in the cornea, which is known as corneal edema. If corneal edema remains for a long term, it will lead to bullous keratopathy, which is basically vesicles and bullae on the surface of cornea, which can rupture periodically. As a result of rupture, you can get ocular discomfort and pain. Plus, corneal edema in general can lead to impairment of vision, photophobia, and also see light halos as a symptom. If you look at the slit lamp, you will see corneal thickness is increased and you will see haze. To manage corneal edema, we can give sodium chloride 5% as eye drops 4 times a day, or 6% eye ointment at bedtime, and as an alternative, we can give anhydrous glycerin. We can also use bandaging or therapeutic contact lens, which will decrease the effects of bullous keratopathy. If it's unresponsive to all of this, we can do a penetrating keratoplasty. I'll talk about keratoplasty in a separate video. Another pathology you can see in the cornea is corneal opacity, which can be seen in 3 grades as a result of a breach in the epithelium of the Bowman membrane. Lowest density one is called a nebular scar. Macular is like a spot, but you'll be able to see the pupil and the iris. Leukomatous is so dense that it covers the iris and pupil behind. This involves only the Bowman's membrane and the superficial stroma. This involves less than half of the stroma, and this involves more than half of the stroma. Next pathology is neovascularization of the cornea with or without infiltration of cells, which is known as pannus, which can be superficial or deep. This can also be superior, inferior, or generalized, and occur in infections like trachoma or exposure keratitis, or in more severe conditions like Stevens-Johnson syndrome or Murren's ulcer. All the deep corneal ulcers, interstitial ulcers, and chemical burns will give rise to a deep vascularization. Mainstay of pannus is going to be to cause vasoconstriction, which can be done with topical corticosteroids, or you can do beta irradiation. Next pathology is pigmentation of the cornea, which can happen in a lot of substances, but the most important is Wilson's disease, where we have a golden brown or a green ring which is seen around the cornea, mainly in the Descemet's membrane. Main investigations to do in a case of corneal pathology are corneal thickness, corneal curvature, and corneal surface. For thickness, you can do pachymetry. Mainly central corneal thickness, or CCT, is important for us. It is 0.5 mm in normal cornea, which is increased in endothelial disease or high IOP. To measure the corneal curvature, we have keratometry. Types of keratometers. All we want to estimate is the corneal astigmatism. Basically, the degree of curvature in two different planes in the cornea is different. I'll cover astigmatism with refractive errors later. And for the topography or regularity of the surface of the cornea, we use a placido disc which we reflect off of the cornea, and you can see whether the topography is regular or not. Now, suppose you have a viral keratitis or a herpetic ulcer. You can use rose Bengal stain to stain the edges of the ulcer, the necrosed base of the ulcer. You can see a dendritic pattern. In cases of dry eye or a basic corneal abrasion, you can do a fluorescein dye staining. Next, you can check corneal sensitivity by using a dry cotton wisp. Now, I'll discuss keratitis and keratoplasty with you in part 2.